Today's lecture 11, we are going to talk about the bones of the lower extremities. So we've almost completed all the bones and the muscles for this unit. These will be the last two lectures for this next exam to finish up Unit 2. So I have a picture here to just kind of describe where this lecture is going to take us. So we're going to start at the pelvis and we'll work our way through the hip joint, through the thigh or the femur. We're going to deal with the hip bone and then move toward the tibia and the fibula and the tibia, and then work on the ankle bones and the bones of our feet. So I'll probably divide this somewhere around here into two lectures for you. So let's start first on the hip bone or the coxal bone. So the coxal bone is made up, so there's two of them, okay, one on each side, and they are made up of three individual bones that fuse together around the age of 25. Before the age of 25, you have a lot more mobility and flexibility in your hips. And this is why Olympic gymnasts reach their peak well before the age of 16. So once these bones fuse together, you have a lot less mobility in your hips. So I'll go on to show you that the hip bone is made up of the ilium, the pubic bone, and the ischium. And these bones, like I said, fuse together. And then both hip bones are connected together by a band of fibrocartilage at the pubic symphysis. The pelvic region is actually made up of both of the coxal bones as well as the sacrum. So we talked about the sacrum when we were talking about the axial skeleton. Let me show you another view of these bones that I got from Teach Me Anatomy that color codes them so you can see how these bones are joined together. Now, I wouldn't ask you to identify each of these, but there are a lot of features to the pubic bone or to the pelvic bone that I want you to know. All right, so in red, you can see the ilium. That is the biggest bone that is making up these hip bones. The pubis is in yellow, so that's the pubic bone in yellow, so here. And then inferior to that is the ischium. So those are the three bones that make up the hip bones. So let's take a look at these features. There are a lot of features to the hip bone, and it'll take you time to work through all of these features. Some of the features, the names of the features do take on the bone that they are located on. So let me get my highlighter and work through these. So again, I know it's a little bit overwhelming. So what I like to do is pick a prominent feature and work from that. So have a starting point and a reference point. Identify that first, and then start to identify the features that are near your starting point. So let's first orient ourselves as we always do. So this is a right hip bone, and it is a lateral view. So we are looking at the socket. So this round area right here, this is going to be where the femur articulates. So I just want to point out that you are looking at a lateral view, okay? So that's important because when these bones when you're looking at them in terms of the full skeleton, you have to rotate these bones, all right? So again, this is a right hip bone lateral. This is a left hip bone, and this is a medial view of it. So it's the other side of this bone. All right, so let's work on this side first, and then I'll show you some of the features that you can see on the other side. So where I like to start is I like to first identify this very large notch over here called the greater sciatic notch. That's always my starting spot. Now you can choose a different spot. I just like to find a really pronounced feature and then work from there. All right, so if you work from the greater sciatic notch, the first thing I do is I work down. And the first thing, so down from there, you're going to see the ischium bone, okay? And you will notice a little bony protrusion called the ischial spine right here. So you can see that. I'm gonna point to it right here. That is the ischial spine. So from the greater sciatic notch going down, you're gonna run right into the ischial spine. From there, you see there is another little notch in the bone called the lesser sciatic notch. And let me point out that all of these features, the reason why we have you learn these features is because they are all important insertion sites or origin sites for muscles. So when we get to the muscle section, you're going to see that a lot of them originate or insert on all of these features that I continue to go over, whether it be the hip bone or the femur, or as we move down, just as you've seen with any of the bones that I've showed you. So that's why these features are important. So I need to back up and say, so I said that you wouldn't need to identify the bones. What I really mean by that is I wouldn't ask you to define the border of the bone, but the general region you should know. So you should make note that the larger bone is the ilium, and then you have the ischium and the pubis region. So if I pointed to that, I would make it very clear of which area I was pointing to, but I wouldn't ask you to know the exact border of those bones. Let me erase some of my drawings so that it doesn't get in the way as I'm going over these features. All right, so after identifying these three features, I'm now gonna go superior. So I'm right here. So coming off of the greater sciatic notch, there are two bony protrusions, and they have long names. The first one is the posterior inferior iliac spine, because we're in the ilium region. And the other one is the posterior superior iliac spine. And these are these bony protrusions here and here. So we're on the posterior side. So one is the superior iliac spine and one is the inferior iliac spine. From there, I'd like to take you to the other side because there are two other bony protrusions on the anterior side with a similar name. So there is an anterior superior iliac spine and an anterior inferior iliac spine. So I like to talk about, that's the order in which I like to start working through the features. Again, working from the greater sciatic notch, going inferior, and then kind of working your way around on each of these sides. At the top is the iliac crest. That's what you're seeing here. It kind of looks like a crest of a wave. There's one other feature that's on the ischium, and it is called the ischial tuberosity. It is a little bony protrusion off the ischium. So I think that kind of sums up the right hip bone lateral view, those features that I want you to know. But I do want to point out something else that's very important. So the acetabulum, that is where the head of the femur, that's this big circular region right here. The head of the femur is going to articulate with the acetabulum. Okay, that's where that ball and socket, those two bones are going to form a joint at that region, at the acetabulum. So another important thing to note is the bones that make up the acetabulum. So you can see from this view, this nice color-coded view, that the acetabulum is made up of all three bones. So the ischium makes up part of the acetabulum, the ilium makes up part of the acetabulum, and the pubis bone makes up part of the acetabulum. Another feature that I want to point out, which I don't have boxed and I apologize, is the obturator foramen. That's this hole that you see right here. That is the obturator foramen. So, and then on the this medial view, I also want you to take notice of the iliac fossa. That is a smoothened area on the ilium. All right, so I want to show you another view and pay attention to the greater sciatic notch. So I put this slide in here because this is what our skeletons will look like and what the hip bone actually looks like when you rotate it back into place. So you can see from this view where the greater sciatic notch is. All right, and you can see that here is the femur and it is articulating in the acetabulum. So I just want you to make note so you're not confused, because the orientation of the hip bone in this picture, as well as probably the pictures in your book, are a little bit deceiving because they're a lateral view. All right, so always take your hip bone that you're working on in lab as you label it or start to memorize the features, and pay attention to how the hip bone actually sits in the skeleton for reference. All right, let's talk about some of the differences between the female and the male pelvis. I have a couple images to show you the differences between a male and female pelvis. So this is one way you can distinguish if a skeleton is male or female. We talked about some of the other features of the skull. And so if you watch any crime shows, or even if you've seen the show Bones, where the woman comes to a crime scene and is able to immediately identify whether a skeleton is a male or female, one of the defining features is to look at the pelvic region. And as I work through these, keep these things in mind. I recently found a complete real skeleton in the lab, and I took a look at it to see if it were male and female. So you could actually do that when you came to lab, as you hear about these features that distinguish a male and female pelvis, and see if you can determine if the skeleton is male or female. All right, so let's talk about those features. So one of the features that you can look for is something called the pubic arch. So this is an arch that occurs when the two hip bones come together and they form an angle. So the angle that you will find in a female is a lot wider than the pubic arch angle in a male. So that's one of the defining features. Here are a couple others, and then I have some images of real skeletal bones for you to see. So another defining feature is the pelvic inlet. So that is the circumference. You can see the hole that is created when the two hip bones come together. And the pelvic inlet is a lot wider in the female. And most of these features that I'm going over have to do with the fact that women bear children. So the baby has to pass through a birthing canal. And so the design of the pelvic region is different for females and males for that very reason. So we just talked about the pubic arch being greater in females. And then importantly, is the way that the sacrum is positioned. So the sacrum and the coccyx, remember the coccyx is the tailbone. So in males, the sacrum is pushed anteriorly. It's positioned anteriorly. So it is pushed forward in the male. And in the female, the sacrum is pushed back. It's posteriorly. So again, leaving room and having the ability to have room for the birthing canal and delivering a baby. So here are some of the images. These are actual bone images of the pelvic region, showing you the differences between the female and male pelvis. So you can see here that the sacrum and coccyx is pushed posteriorly, whereas in the male, it is pushed anteriorly. It's pushed toward the front. So there's no actual, there's not a lot of space there compared to the female. And again, that is for delivering of the baby. Here's a view inferiorly, so you can see the amount of space, the actual inlet looking at the inferior view. So you can see the space here in the female pelvis compared to the male. So those are the defining features. It really has to do, again, with childbearing and the placement of the sacrum. All right, now let's switch and we're going to move distally and we're going to talk about the femur. And the femur has some similarities with the humerus. So some of the features like the epicondyles you're going to see again, but there are some different names that we'll work through. So we have an anterior view on the left side and a posterior view. And again, it's going to be important to make sure if you're grabbing a left or a right, what view you're looking at, whether it's anterior or posterior. So always orient yourself when you're sitting down in lab and holding on to a femur. Lots of times there may only be one femur in your bone box. So you need to distinguish if it's a left or a right and then figure out anterior from posterior. So let's start at the proximal end of the femur. So just like the humerus, there was the head of the bone that is going to articulate, if you remember, with the acetabulum, okay? It is also called the fovea capitis. There's a little region here that I'm going to talk about in the next slide. There's a ligament that attaches there that is going to help secure the head of the femur into the acetabulum. There is a neck region, so here's the neck, here's the head, here's the fovea capitis. And then just like there was a greater and lesser tubercle on the humerus, which are attachment sites for muscle, there is a greater trochanter and a lesser trochanter on the head of the femur that has to do with muscle attachment. As we move down distally to the end, now this part over here is going to form the knee joint, which is a very complex joint. I'm going to spend a lot of time actually talking about the knee joint. We did kind of gloss over a lot of other joints, but I think the knee joint is important to take a look at and learn the ligaments and everything that is supporting the knee joint. So this is somewhat of a complicated portion of the femur because there are a lot of articulation sites. So let's work first on the anterior view. So this smoothened surface right here is the patella surface. All right, so the patella, the knee bone, is going to sit on that surface. On each side, there are epicondyles. So there is a lateral and a medial epicondyle. So again, when you are deciding if it's a lateral or a medial epicondyle, you have to have the bone in the right orientation or you're going to mix up which condyle is which, okay? medial closer to the midline, lateral away from the midline. All right, so if we look at the posterior view, we can see a couple other features. So not to make things complicated, but there are also medial condyles and lateral condyles. And this is what is going to articulate with the tibia. So you have the lateral condyle and the medial condyle. And that's what both of these are. And that's what is going to articulate with the large shin bone, which is the tibia. So that bone is going to sit down on top of the tibia. I'll show you that in the next slide, how that happens. All right, and then there is a fossa in between the two condyles called the intercondylar fossa. Gosh, I am not using my pen very well today. I apologize. So I'm going to highlight this one too. So we've systematically gone through the features of the femur. It's important to know the features and to start working on the features as you sit in lab and to understand what some of these features are doing, especially if they're involved in articulations. All right, so let's look. And this slide is not needed. I just removed this slide. It's just a redundant slide. You can use a slide like that though to label the features. So again, making good study guides with the bones labeled and then having them unlabeled while you write in the actual labels is always a good idea. But what I want to do is show you how this end of the femur is going to articulate with the tibia and the fibula. And then we're going to come back, talk about the knee joint. And then on the next lecture, we will work our way down to the foot and the arches of the foot. All right, so moving on. So here is how the femur is going to articulate with the hip bone. So remember that in the hip bone, there is the acetabulum. That is the cavity that the head of the femur will articulate with. And just like we saw with the humerus and the labrum, there is also a labrum because this is not a particularly deep socket either. So having these fibrocartilage labrums in this area helps to deepen this socket. So this is also a synovial joint. So you can see the acetabulum in yellow. The acetabular labrum, again meaning lip, is in red. That's going to help deepen the socket. And there is also a ligament on the head of the femur that I began to talk about. Do I have another picture? I do. All right, so there is a ligament that is going to attach the head of the femur into that socket. And that ligament is called the ligamentum teres. All right, so this ligament right here will attach in the acetabulum, and that will help secure the femur head into this socket. So that little dimple that was on the femur head called the fovea capitis is the area in which the ligamentum teres is coming from. All right, there, spelling, always important. So this slide is an exact duplicate of what I just went over, but I want you to pay attention to this distal end here as we're talking about the tibia and the fibula so that you can see how these bones will articulate with each other. So here is an anterior view of both of those bones. Here is a posterior view of both of these bones. And what I want you to make note of is this surface here that is going to be the surface. This is the articulating surface for the medial and lateral condyles. So these two condyles right here are going to articulate with the tibia. And there are two smoothened surfaces for those two regions to sit down on, okay? So these are the features of the tibia and the fibula. There aren't as many features, all right? The bones are more or less pretty simple. So starting with the fibula, the only thing that you really need to notice is that the fibula does not articulate with the femur, okay? So you have the head of the fibula and it's articulating with the tibia. And then there is what's called a lateral malleolus here. All right, that's a bony protrusion sticking out at the distal end of the fibula. And the tibia also doesn't have a lot of features. It has those articulating surfaces for the femur. And then the only other thing that you will notice is if when you hold the tibia in your hand, you can feel the surface. So this is, you can actually palpate it right now. It's a little bit below your knee, your patella, your knee bone. You can feel a bony protrusion sticking out. That is the tibial tuberosity. So palpate that region on your upper shin, right below your patella. You can feel a bony protrusion, and that is the tibial tuberosity. The tibia itself also has a lateral and medial condyle. So again, it's very critical that you have the bone in the right orientation, or you will miss those on a practical. You might get them backwards. So make sure that you have them in the orientation. So one way you can be sure is to look at the medial malleolus of the tibia and to make sure that it is medial, okay? So like that probably didn't make any sense. To make sure that the bone that you're holding, whether it's a left or a right, and look for the medial malleolus. You can always use your own body as a model to see if you have the bone in the right orientation. Just like the ulna and the radius, the tibia and fibula also have an interosseous membrane that goes between the two bones to stabilize these two bones. So before we move to the foot, the ankle and the foot, I do want to take some time and talk about the knee joint and all the components that make up the knee and stabilize the knee. All right, so let's talk about the stability of the knee and all of the components that stabilize this portion of our body. So first of all, the knee joint is considered bicondyloid because there are two condyles, two distinct surfaces that sit down or articulate with the tibia. It's also worth noting, and I forgot to mention this when we were talking about the tibia and the fibula, to always realize that the tibia is medial and the fibula is lateral. So just as we talked about in anatomical position, the radius and the ulna, it is important to know which one is medial and which one is lateral. Okay, so the movements that you can get at your knee, that you have at your knee, so you can have flexion and extension at the knee. There is also a very small amount, a very small degree of medial and lateral rotation. You can really only feel this rotation if you are standing up and you go from unlocking your knees to locking your knees. If you do that really slowly, you can feel a small rotation that happens right at the end, right as you're about to lock your knees. also, if we look at the articulations, okay, so we discussed the fact that the femur is articulating with the tibia, and it is not articulating with the fibula. So you can see how the fibula sits a little bit inferior. So there's no real articulation, bony articulations there. There are going to be some ligaments that we'll talk about that will stabilize that side of the knee. And then we also talked about that patella surface. So the knee, the patella, is going to sit, it's going to cover this joint and kind of sit like this over the femur and the tibia. And I'll show you other slides that I have showing you that articulation. All right, so those are the basics that cover what is articulating with what, which bones articulate with which, and kind of just shows you the orientation of the tibia and the fibula. Now let's get down to the nitty-gritty of what's going on in the knee. So there are menisci of the knee. There is a lateral meniscus and a medial meniscus. So this one is, of course, from Teach Me Anatomy. It's color-coded, which is why I like it. So the medial and lateral menisci, these are two pads of fibrocartilage. All right, and they're going to serve two different functions. And these are the same, a lot of the same kind of functions you'll see with any type of fibrocartilage. If you remember, like the labrum, okay, in both the arm, in the shoulder socket, as well as the hip. So these pads of fibrocartilage are going to deepen the articular surface of the tibia with the femur. And it's also going to increase stability, so that's going to help increase stability. And then finally, it's going to act as a shock absorber. Since we are running and jumping and doing all the things that involve our knee, these are nice fibrocartilage pads that help protect this joint. Two other things about this. So the medial meniscus, is in purple. The medial meniscus is fixed, and I'm going to come back and talk about what this ligament is, but it is fixed to another ligament, or the medial meniscus is fixed to a ligament called the tibial collateral ligament, or TCL for short. So that's what you're seeing in green. So it has this extra piece of attachment to help stabilize that meniscus even more. The lateral meniscus, which is what you see in red, does not have this extra attachment, and it is a little bit smaller than the medial meniscus. So two things that I want you to do when you're in lab. One of them, actually I forgot what the second one, no, one of them. One of them is that we have a really nice model of the knee joint. So you can sit with the knee joint, and the knee joint model that we have in lab has all of the ligaments. It also has the menisci, the two pads of fibrocartilage, and it shows you the articulations that are occurring. So it almost looks just like this, so that you can identify that, all the things that I'm about to go over, and I can use it on the practical as well. It'll give you a good foundation for beginning to study all of these things that stabilize the knee. And I can't remember what the second point was, but I'm sure if it comes to me, I will write it down. But take a look at that. Okay, so that's the menisci of the knee. Let's now start talking about the different types of ligaments that you're going to find here. All right, so I have several slides showing you a couple ligaments at a time so we can kind of work through these. Oh, I know what the second thing was. I knew it would come back to me. So when you are writing, if you are asked to write about the knee joint or anything for that matter that has a name that can be abbreviated, the general rule is you need to write it out at least once. So don't memorize just these abbreviations. Make sure you know what they stand for. And then once you wrote out tibial collateral ligament or whatever it is that you're going to write out, you could put in parentheses TCL and then use that as shorthand. I just don't want you to get in the habit of abbreviating things like the ACL or PCL, which is what we're about to talk about. I know it happens clinically, but since we're learning and we're in class, it's important that you know what they stand for. All right, so let's get back. We're actually going to talk about the ACL and PCL now. So what I'm going to go on to show you is that because we use our knee so much, so it's utilized so much in all of our actions, there are ligaments that occur within, side to side, and front to back that pretty much cover all the different ways that our knees can get damaged. So they're going to protect all of that. So the first two ligaments I'm going to talk about are called the anterior cruciate ligament, or ACL, and the posterior cruciate ligament, or PCL. Cruciate in Latin means to cross over, and that is actually what these ligaments are doing. So you can find them, they're in the front and the back. So the anterior one is going to be in the front, the posterior one is in the back, and they are going to crisscross over. They are going to be within that intercondylar space here. You're going to see it there. So if you bend back the femur, you can begin to see these ligaments. And sometimes, depends, and I'm not sure if you guys have this with your cadaver, but we've cut off the patella and on one of our cadavers at Palomar so that you can lift up the knee and actually see the ACL and the PCL. So we'll have to see. So you can see here the patella is cut and removed. And then again, here's the femur. And if you pull that femur back a little bit in the posterior position, you can open up this joint and begin to see these two ligaments. So that's what they are for, and they're going to secure the tibia to the femur. So that's going to help control the front to back movement. All right, and then on the sides, there are additional ligaments, and they have two names. I don't care which name you use. You can pick whichever one is easier for you. I mean, either one works, but one of them tells you exactly where it is. I mean, they both kind of do. But so there's the tibial collateral ligament. So that is going from the tibia up to the femur. And then there's the fibular collateral ligament, which is going from the fibula up also to the femur. So other people refer to them as the medial collateral ligament and the lateral collateral ligament. That's a mouthful. And then you can use these abbreviations, MCL and LCL. And what these ligaments are going to do are they are going to protect the knee from side to side movement, okay? So they're going to stabilize the knee at the sides. All right, now let's look at the front and the back of the knee. All right, so the patella bone, so right here you can see the patella, is actually embedded in two ligaments. Well, one's a tendon and one's a ligament. So actually this is named wrong. This is a ligament. So interestingly, people always call it the patella tendon, even in textbooks and figures. But if you remember, a ligament is what connects bone to bone. And I'm not actually sure if I told you this or not. And a tendon is what connects muscle to bone. So you will sometimes hear people call it the patella tendon. You actually hear it quite often, but it is actually a ligament. So anyway, let's get back to the point. The patella ligament, I guess I wrote it out here for you, so to correct it, is going to, the patella ligament is going to attach to the patella itself and also to the tibia. Okay, so that is what is supporting and stabilizing the patella, and it's also stabilizing the knee on the front. The patella is also embedded in the quadricep tendon. So the quad muscles, which I haven't talked about the quadricep muscles yet, but I will towards the end of this lecture, or probably the second part of this lecture, is a big muscle that's running, well, the quadriceps actually are 4 muscles that run on the upper thigh, but this one in particular has its tendon attaching to the patella. So it's really embedded between the muscle and then down here at the tibia. So when you're looking at the patella, it's always embedded in tendon and ligament. So when you see it on a cadaver, you'll see how it's embedded between the two. And since the quadriceps are the most powerful, some of the most powerful muscles in our body, that is going to stabilize the front of the knee and also protect it from damage. So this is the anterior view, of course. And then if we look, so that's what's stabilizing the knee from the front. If we look at the posterior view of the knee, there is a popliteal ligament. This is actually should be a popliteal tendon. Sorry, gosh. Okay, so it is off of the popliteus muscle. So here's the popliteus muscle, and then you can see the tendon here is attaching. So this muscle kind of runs diagonally across the back of the knee, and so this is going to stabilize between the patella and the popliteus muscle. You're going to get front to back stabilization. I actually borrowed this slide, so I didn't catch these errors when I added it to my lecture, so I apologize. I didn't make this slide myself. All right, so we've just discussed the ACL and PCL, the anterior cruciate ligament and the posterior. That's stabilizing within. We talked about side-to-side stabilization, and now we're talking about front-to-back stabilization of the knee. So there's a lot of stabilization happening and protecting this widely used joint. But that's not all. There are actually other places that stabilize the knee. And this is something that is really cool to see in the lab. If you're a runner and you've heard of the iliotibial tract, okay, so the iliotibial tract is also called the IT band. Again, you can call it the IT band to me and you and your partners in lab, but make sure that if I mark it on the practical that you write out iliotibial tract, okay? So what the iliotibial tract is, it's a very thick band of fibers that starts up here at the hip. So it runs and it begins at the pelvis and it runs all the way down the thigh and across the knee. So it attaches into the tibia. Okay, so it is a fibrous band. It's really interesting to look at when you're looking at the cadaver. It's really nicely isolated. It was one of those things that for me, it was not at all what I expected it to be. So sometimes we imagine things and what it would look like or feel like. And so I would urge you to definitely take a look at the iliotibial tract with one of the cadavers, because it's really interesting to see this fibrous material run from the hip all the way down to the tibia. embedded in that area. So there is a muscle here. You can kind of see it. I guess I could pick a different color to kind of outline this muscle right here. This sounds like a Starbucks drink. This is the tensor fascia latae muscle. This is a big muscle that runs on your hip, and the IT band encircles it. This is this is a muscle that helps to stabilize not only the IT band, but also the knee. So I've went over several different features of how our knee, this joint that we use so much, is stabilized. And I want you to make a list when you're making your notes and talk about all of these different ligaments that we talked about, muscles, anything that we went over that helps to stabilize the knee. This is all going to be important. And it's not good enough in this scenario, this situation, to just list components. You must know what those components are doing and how they're helping to stabilize the knee. The last thing I'm going to talk about is the last thing before I stop this video and make another one. The lecture is hardly near being over, so I apologize. I make these in clips and then I piece them together. I want to talk about what it means to lock your knees. So we have this ability that if you're in full extension, if you're standing up, you can bring your knees a little bit in the posterior position, and your knees and your legs and your knee will lock, okay? And so this provides, this is actually not a great thing to do for several reasons. So when you begin to lock your knee, you can begin to feel that slight rotation that I was talking about. It's not so important. I don't know that I need you to know why. What I need you to know is what it means to lock the knees. So the menisci are as close together as they can be. And although this mechanism, so this slide is written, I don't know, it's not exactly the way I would have written it, that there is some advantages to locking your knees so that you can stand supposedly for long periods of time. But in actuality, locking your knees can be very bad and very detrimental because you lose blood flow when you lock your knees. So I would say that it does not permit standing for long periods of time. So a good example of this is if you know anybody that's in the military, or if you've been to Buckingham Palace where the guards stand for long periods of time, what happens is you eventually lose blood flow. So if you lock your knees, you're inhibiting blood flow to flow back up from like the deep, or your feet. So like the blood that is in like your ankles has to drain back up to get oxygenated again. And what happens is if you prevent that blood flow from happening, you can end up passing out. It happens to the guards at Buckingham Palace. It can happen if you're in the military and you stand attention for a really long time and you've locked your knees. The best thing to do is actually unlock your knees every once in a while to allow for blood flow to happen. All right, so that's the deal with locking the knees. I actually think it's more beneficial to unlock your knees. I realize that sometimes, in the military or like the situations I just described, you're not really supposed to do that. But what can happen is you can end up passing out. All right, so the next part of the lecture, we're going to move down to the ankle and talk about the bones of the ankle, just like we talked about the wrist bones. We'll talk about the bones of the feet, and I'll go on to show you how the arches of the foot are constructed.